there, Meg.
Okay, so we are recording all the breakout sessions, so just to let you all know that this now is recording. I will be the host in this breakout from HE point of view, so I'll be letting people in, and I'll keep an eye on the chat box for you, Emma, and I'll just be making some notes of conversations and points. So I keep clicking mute all, so if I do that, I'm really sorry. But I'm really pleased to introduce Emma Edwards from Keele University, who is going to talk to you about piloting MDC placements. So I will hand over to Emma.
Hi, I'm going to start with sharing my screen. So can you let me know if it's working?
Yeah, will do. Yeah, we can see. Yeah, we can see that. That's brilliant, Emma.
Yeah, so good afternoon. So this afternoon's discussion is going to be about piloting a multidisciplinary placement. So I'll introduce myself. I'm Emma Edwards. I'm a radiographer by background, but I'm also the Deputy Practice Experience Lead for the School of Allied Health Professions at Keele. So I'm involved with clinical placements for physiotherapy and radiography. And we also incorporate our Faculty of Medicine and Health Sciences into our placement ideas. So, what are we going to talk about by the end of today's session? I want to define what multi and interdisciplinary team working is, highlight the drivers for innovation, discuss new potential models of multidisciplinary team placements, and explore and discuss some of the challenges and opportunities which we come about, and have some discussions around this topic. Okay, so what is a multidisciplinary team working? So multidisciplinary team is a group of professionals consisting of one or more disciplines who together make decisions regarding recommendations for treatment of individual patients. We also incorporate interdisciplinary working. So interdisciplinary approach relies on health professions from all different disciplines alongside the patient, and they work collaboratively as a team to provide the best service. So what are the drivers for innovation? The elephant in the room is the COVID-19 pandemic. We're all aware we've had to adapt very rapidly to benefit the students' learning experience through this pandemic. I've also listened to our student voice and feedback. They enjoy working collaboratively. They don't just want to be pigeonholed in a radiography placement or a physiotherapy placement block. We want to foster collaborative partnership working with the HEIs and the placement providers. We want to bridge the gap between academic and clinical education and make it more a teamwork approach. We want to facilitate and optimise shared resources across the trust and the HEIs collaboratively. We want to help shape future health professionals' understanding of excellent multidisciplinary teamwork, as this is required by the HCPC. By applying interprofessional learning from day dot as a first year student, they will transfer these skills into their graduate practice. We also want to streamline the student learning experience. We want to coordinate, we want good models of practice which is shared, and expansion of our practice-based learning. By doing this, there has been research which has demonstrated this improves patient outcomes. We all have different views and voices. If we work collaboratively, this will really help improve healthcare provision. And we could work collaboratively as part of an integrated care system. So here's some examples which we're hoping to pilot in the forthcoming future. So for example, a stroke patient. So the students could shadow and observe on a clinic appointment, the physiotherapy and the OT therapy clinic, the ward rotation, the imaging, and this just be with when they first attend, and then their follow-up imaging as well, so when they visit the outpatients clinic and when they're on the ward. Depending on the type of stroke, they may go to theatre, so we could have the neuro theatre placement option, and here they could work closely with an ODP. This is where the collaborative working would really come into force, and we would use reflective practice. So the HEI setting could facilitate this, which would help limit the space needed in the clinical settings. So we could facilitate the reflective practice of all the students which have done this pathway and learn from best practice and what could have improved. We can also reinforce evidence-based practice when we're doing the reflective practice, and we could think of research and audit elements to incorporate. So what are the key skills which are developed? Communication, understanding of everyone's job role, and better understanding of the patient pathway and putting the patient first. Here is an overview of how many different disciplines we could incorporate and get the students to shadow as they rotate round the patient pathway. So paramedics, but this could be done virtually. I understand how small an ambulance setting is. So is there any virtual software we could use to show a patient pathway through the ambulance? Doctors, physiotherapists, OTs, radiographers, radiologists, anaesthetists, ODPs, nurses, nurse practitioners, dietitians, the SALT team, and we could implement the research team as well from the trust. So another idea is a neck of femur patient pathway. So when they arrive in the ambulance through A&E, then they go on to have the surgery. They could then shadow them on a ward rotation. Quite often they'll have CT involved in this patient's managing. So from imaging, there's more perspective for rotation around that area. Theatre, DHS is our bread and butter as a radiographer, and from a theatre perspective, they happen routinely. So there is that opportunity to rotate round the DHSs in the theatre. They could then shadow in the post-operative clinic and the community rehabs if the patient's gone home and they need rehab. Again, depending on space, this could also be something we could think about implementing virtually or through simulation. Again, we would reinforce the reflective practice, the evidence-based practice, and the research. Another common example which we could really utilise is a cardiac arrest patient or an MI patient. So here they could shadow an ECG technician and understand the intended learning outcomes for ECG. They could shadow on a coronary care unit. And with this, we could incorporate a little bit of intensive care rotation to build resilience in every single student we're sending out on clinical placement. Again, they may observe surgery or interventional procedures in a cath lab, and we would incorporate from the HEI's perspective the reflective practice, the evidence-based practice, and think of ways to continually improve that patient pathway with research and audit. So what are the advantages? Okay, from the students, it really improves their multidisciplinary team communication. They have confidence from year one interacting with a range of different disciplines. It also helps them understand the different roles the MDTs do. Okay, and that will help them become a more rounded professional. It improves their confidence in multiple scenarios. So this really reinforces resilience, which we want all our newly graduates to have, especially during a COVID-19 pandemic. If they're working out of hours or on call, they have had exposure to stressful situations prior to being a lone worker. Really helps them understand the patient pathway and not only their job description role in that, but as the whole team. And it helps give them leadership. Okay, if they see something, as we've just seen from the students before, they've got some fantastic ideas and they're our future. So we should be giving them the opportunity to make changes from year one of study. And it's going to make that 21st century healthcare professional, which we've been discussing today. So for our placement providers, why would this work for you? It showcases your trust's expertise. You all have a different area of interest and speciality. It enhances future graduate recruitment. So the more students you've got rotating around your hospital, the more likely that they're going to apply for that trust in future. It improves the interprofessional working in the trust, not only with the students, but with the qualified members of the team. With this and having a bit more understanding of everyone's job role, this will increase staff morale and everyone gets to know each other a little bit more, which raises the staff profiles. Also finance, more students rotating around, the more student tariff funds you will receive. We could look at different supervision models, which was discussed earlier. So we could have a 3-to-1 model or the click model and utilise the students to support this learning opportunity. Again, we could use all different necks of the woods of our placement providers. So we could incorporate our private sector and our NHS and our community-based sites as well, and work collaboratively and work in partnership with the HEIs, because we all have the same goal. We all want to get our future workforce resilient and ready for future practice. So for HEIs, what is the benefit? We do interprofessional education in a HEI setting, but it would really reinforce the learning in a clinical environment. Okay, the student feedback is they learn more when they're hands-on and they're seeing the patient interactions face to face. It will enhance partnership working. We can make it contemporary. We can reflect collaboratively to really make it the future. Again, we can evaluate the impact on student learning as well as the patient experience and outcomes, and change this with feedback and audit as this progress goes through. It will also help design future research studies and make recommendations for future practice. So what are the disadvantages? Okay, for every good idea, there's going to be some disadvantages. So training for practice educators, making sure it's parity of student experience across all our providers, and setting realistic educator expectations from day one. At different sites, there'll be different areas of rotations available. So planning off this can be quite a challenge at first. The varied skill sets of staff. You may have some junior members of staff only operating in one area compared to seniors in another area. So how can collaboratively we support this so that the staff members are highly skilled and feel supportive? And initially, it's going to be time consuming. Organising the rotation, the training of all the practice educators and the facilitating will be timely. However, as that progresses, that should really pay off. So some discussion points I wanted to put across today is, what are the experiences of others? Do you have any future ideas to really make this a success, or any feedback where you think you've tried this before and this hasn't worked because of X, Y or Z, or potential barriers? We're looking to pilot this on a small level. However, the more of us involved, the better this experience is going to be. So I'd like to open the shop floor now and see what your ideas and thoughts are.
Thanks, Emma. That was really interesting. Does anybody want to start off with their thoughts around Emma's presentation and around an MDT model? Anybody, as Emma said, tried that in practice? Delia, I think your hand was up first.
Hello, Emma. Thank you for
Hi.
the presentation. I'm really interested in this model moving forward. Quite a few years ago now, I was involved in this from a nursing and mainly medical student point of view. And one of the issues that we had with it was the disproportionate number of nursing students to other professions. And I'm just wondering whether there is sort of, you know, any top tips of how potentially that can be managed.
So looking at the different models, so instead of having a 1-to-1 and maybe having 3-to-1, that would really benefit.
Yeah.
Also looking at simulation where possible. and having like team reflections and case studies, like the MDTs, they could do live, or we could do a role play version of them. That would make the balance a bit more achievable.
Yeah.
And then I think if we split the nursing into the different disciplines, so we've got the Band 5 nurses, the advanced practice nurses, and really utilising like the sister on the ward for the day and getting the leadership skills with them. It's thinking about everyone we can use.
Yeah, okay. Yeah, thank you. Some good ideas.
Thanks. Soraya, your hand was up next.
Thank you, Meg. Thank you very much, Emma, for that. That was really, really interesting. Just a quick question around just the layout of the placement. Is every element of it a shadowing element, or is an element built into the model where they actually have some clinical hands-on opportunities?
Yeah, so when they're on the wards, they can take the OBS. It's just working within their scope of practice and within their supervision guidance. So we couldn't have in radiography, for example, we couldn't have a nurse come and expose an X-ray or perform a CT scan, but we could help show them how to do that.
Okay, so if I'm thinking particularly, say, from a physiotherapy perspective, where it's harder to just pop in and do an intervention on a patient and move on, because you tend to work more on developing that rapport. So I'm assuming you could still, on a ward environment, let them work alongside that team and see how they can support for that afternoon or so and get some face-to-face interaction. Okay, now
and
that's
also
great.
doing the case studies work as well within that discipline.
Okay, that'd be great. Thank you so much.
No problem.
Thanks, Soraya. Rob, I think your hand was up next. I'm just conscious of time in that the next session starts at 2. So if people want to jump off at 5 to have a quick break, that would be great. If anybody else has got questions they want to pop in the chat box, as with the other questions, we can put them to Emma and get some responses afterwards. But Rob, do you want to go?
Thank you. I think just a comment really, that sometimes I'm head of allied health professions at UHNM in North Staffs, and I think probably one of the bits of enabling work, I'm absolutely a real supporter of multidisciplinary learning, is to make sure that the professional bodies align what their expectations are of students. Having managed a variety of AHP and non-AHP professions with undergraduate students, often the bodies that recognise the clinical practice as part of the degree ask for not necessarily things that are in line. So I think probably we've got a bit of work to do around getting professional bodies to come together to find some commonality and recognise new ways of working.
I agree, Robert. I really do think that's a valued point. I think with the COVID-19 pandemic has really highlighted the need that we need to be more flexible. And obviously this is the initial piloting stages, and more professions working together will give us that information that we need, and we can always go to the HCPC and the professional bodies to get the exception that we need. The students who have reflected on this think it would really help their learning journey, so that's why I'm key to facilitate it, and we could utilise areas where the students in that area aren't currently, to increase the capacity which is needed at the same time. But thank you, Robert, good point.
Emma, somebody's just asked in the chat box if you're happy to share your email address.
Of course.
Brilliant. And then I think Pete, your hand was up next.
Thanks both. Hugely supportive of it. So my background is in paramedic at University of Wolverhampton, and we've just had quite a lot of experience with our third year students going into placement in various areas of both City and Sandwell hospitals. And it's been a real mixed bag in terms of what actually happened. And I think there are two things that I really would advocate. Number one is making sure that the student body understand what they can gain from those placements. Because I had paramedic students saying, I'm not going to get anything from a critical care placement. And you think, really? And then the other side of the coin is also paramedics are very different to nurses and very different to physios, and physios are different to OTs. And I think it's really, really important that mentors, practice educators have a very good understanding of the skill set of the individuals that they're looking after, and also what they actually require from the placement. So wholly supportive, but just few comments from recent experience.
Yeah, no, and that would be highlighted in the practice educator training. Each profession that's involved, we would outline the key elements for that.
Brilliant, thank you. So as I said, I am just conscious of time. Kelly, your hand went up and then went back down again. Elaine, are you happy to put your question in the chat box? And then Kelly, did you want to come in?
Thank you. Yeah, I just want to say that was really good. Thank you, Emma. I thought it was a really valid point around the advantages with students do IPE at university, and I think we do get quite a bit of feedback that they sometimes don't see the value of that because it's done online, it's done in forums, it's done every so often, and I think they struggle to transfer that to a clinical setting. So I think it's a really good point that they would actually see the value of transferring that IPE at university to a clinical setting if they had these opportunities. And just in relation to some of the other questions, you know, we've done with physio before, you know, some multidisciplinary placements with nursing, and to be able to make sure it was focused, we did clinical competency checklists. So we looked at actually what they needed to get out of the placement, did like a checklist, and they would take that round with them. So in regards to how hands-on they could be, you know, they could get some nursing skills being involved in OBS, or look at how, you know, you do bed making and things like that. So you can focus their learning by having quite a you know, a checklist that they take with them, and then they've also got evidence to put in their portfolio.
Yeah, speaking from experience and using those checklists with physio students that have come out to Walsall, it's really helpful actually, I think, for the placement areas that are supporting a student that's not maybe traditional to that area, and from an oversight point of view, they were really useful. So I am really conscious of time. The next session does start in where are we? In 3 minutes time, so I'm conscious of everybody to have a break. Please do put any other comments and questions into the chat box. I will make sure they're passed on to Emma. Emma, are you happy to share your slides as well?
Of course.
Yeah, and as we said, all of these will be recorded, and all the recordings will be put on a outward facing web page for everybody to access after today's event. So thank you very much, everybody, and enjoy the rest of the afternoon.
Thank you.
Thanks, Emma.
Thanks,